Congenital myopathies. The congenital myopathies are a clinical, histopathological, and genetic heterogeneous group of rare hereditary muscle diseases that are defined by architectural abnormalities in the muscle fibers. Their estimated prevalence is 1 in 26,000, and they are the cause of 14% of all neonatal hypotonia cases. First symptoms usually occur from birth or in infancy, but an increasing number of cases with symptom onset in adolescence or adulthood are being identified. Congenital myopathies usually present a slowly progressive or stable clinical course. In most cases, there is normal intelligence, and the central nervous system usually is not involved. Typical early clinical signs in congenital myopathies are hypotonia, floppy infant syndrome, muscle weakness, hypertrophy, and/or delayed motor milestones. In many patients with congenital myopathies, a myopathic face, and in some cases, ptosis and ophthalmoparesis, can occur. Facial weakness can be very pronounced, sometimes necessitating a feeding tube in the neonatal period and leading to a mouth held in an open position. Facial deformities such as an elongated face, micrognathia or high-arched palate, and skeletal deformities such as scoliosis, pectus excavatum, hip dislocation, or club feet are also frequent clinical findings in congenital myopathies. In case of prenatal onset, polyhydramnios, fetal akinesia, and arthrogryposis can be present. Patients with congenital myopathies often have respiratory and/or bulbar involvement, but usually no or only mild cardiac affection. Except for the complication of cor pulmonale caused by respiratory insufficiency, cardiomyopathy is not a typical feature in congenital myopathies. However, cardiomyopathy can occur in congenital myopathies due to mutations in the gene that encodes slow skeletal B cardiac myosin, MYH7, or titin, TTN, or rarely a skeletal actin, ACTA1. Importantly, in some congenital myopathies, fully ambulatory patients can present selective respiratory muscle involvement, resulting in nocturnal hypoventilation. Most patients with congenital myopathies will survive into adulthood except when serious respiratory insufficiency and severe weakness are present in childhood. Two exceptions are myotubular myopathy, caused by myotubularin 1, MTM1 mutations, in which a high percentage of patients with infantile onset die very early in life, and patients with ACTA1 mutations and severe neonatal affection, since they usually die before their first birthday. Although exact numbers on survival are lacking, the overall life expectancy in patients with congenital myopathies is diminished because of long-term respiratory and/or cardiac complications in some congenital myopathy subtypes, depending on the genetic defect, for example, mutations in SEPN1, TTN. Pregnancy and labor in female patients with congenital myopathies are usually possible, but special measures should be taken when proximal weakness in the lower limbs and pelvic girdle muscles is present, and in case of anesthesia, for example, cesarean section, trigger-free anesthetics should be used to prevent malignant hyperthermia, especially in cases with RYR1 mutations. Before pregnancy, and in case the causative genetic defect of the myopathy is known, novel pre-implantation techniques can be applied to prevent inheritance of the disease to the offspring. Creatine kinase level in the serum is usually only slightly increased or normal. Electromyography mostly shows myogenic changes, but can also be normal. Furthermore, neurogenic abnormalities can occasionally be seen in cases of severe neonatal presentation or in distal muscles later in the course of the disease. Muscle magnetic resonance imaging of the whole body or the proximal and distal legs can be helpful in the diagnosis of some congenital myopathies where a pathognomonic selective muscle involvement can be detected. Muscle biopsy in congenital myopathies is characterized by a non-dystrophic pattern, in contrast to the congenital muscular dystrophies, and the presence of architectural changes in the muscle fibers. Congenital myopathies are subdivided by the predominant structural pathological change on muscle biopsy, resulting in 5 subgroups: 1. Core myopathies, 2. Nemaline myopathies, 3. Centronuclear myopathies, 4. Congenital fiber type disproportion myopathy, and 5. Myosin storage myopathy. In addition to light microscopic examination, Electron microscopy often plays an important role in the histopathological diagnosis of congenital myopathies. Core myopathies comprise the most frequent congenital myopathies, subgroup and mutations in the ryanodine receptor 1, RYR1 gene, are the most frequent genetic cause of congenital myopathies to date. The relationship between the congenital myopathy's phenotype and the genetic cause is complex, since some congenital myopathies can be caused by mutations in several different genes, and mutations in one and the same gene can lead to different congenital myopathies phenotypes, for example, ACTA1, online supporting information. Moreover, the same genetic mutation can result in different pathological phenotypes in distinct members of a same family or in a same person at different ages. Next-generation/massive parallel sequencing techniques, such as whole exome sequencing, are being used in routine diagnostic workup of patients with congenital myopathies, which result in the identification of several novel causative genes and additional pathogenic variants in known genes. This has led to the expansion and increasing complexity of the clinical and genetic spectrum of congenital myopathies. Classification of congenital myopathies. Some histopathological features are common to most congenital myopathies, such as marked type 1 predominance or even type 1 uniformity and type 1 fiber hypertrophy. The subdivision of congenital myopathies in 5 subgroups is determined by the main structural abnormality on the muscle biopsy. 1. Core myopathies. Core myopathies include central core disease and multiminicore myopathy and are characterized by the presence of mini-cores in the muscle fibers. Mini-dot cores are distinct areas of myofibrillar disruption that are lacking mitochondria, which is visualized by the absence of oxidative enzyme activity located centrally or at the periphery of the muscle fibers. In central core disease, there is typically one large, usually centrally located core in the muscle fibers, whereas in multiminicore myopathy, multiple focal areas lacking oxidative enzyme activity are present. Electron microscopy is especially useful to identify the smaller focal areas of myofibrillar disruption corresponding to minicores. The main cause of central core disease is a mutation in the ryanodine receptor 1, RYR1 gene, whereas in multiminicore myopathy, 9 causative genes have been identified so far. Importantly, some patients with RYR1 mutations show susceptibility to malignant hyperthermia. 2. Nemaline myopathies. Nemaline myopathy is defined by the presence of nemaline bodies or rods in the sarcoplasma and/or nuclei of the muscle fibers. Using the modified Gomori trichrome technique, nemaline bodies stain red. Nemaline rods show reactivity for actinin, actin, and other Z-band filaments at immunohistochemical reactions. If muscle fibers are very small or when the rods occur exclusively in nuclei, which can be the case in ACTA1-associated nemaline myopathy, it can be a challenge to detect the rods. In these cases, additional ultrastructural analysis, electron microscopy, can be useful. On electron microscopy, rods are electron-dense structures with a lattice structure like the Z-disc, and sometimes they are in continuity with the Z-disc. Interestingly, there is no correlation between the total number of rods and the number of fibers containing rods on the one hand, and the severity of the clinical phenotype on the other. So far, 13 genes have been shown to be the underlying cause of Nemaline myopathy. The most frequent genetic cause of autosomal recessive Nemaline myopathy are mutations in the Nemaline gene, NEB, whereas heterozygous pathogenic variants in the askeletal actin gene, ACTA1, are the most prevalent cause of autosomal dominant Nemaline myopathy. Core rod myopathy, cap myopathy, and zebra body myopathy are pathological variants of Nemaline myopathy and are therefore part of the Nemaline myopathies. Core rod myopathy is characterized by the presence of both cores and Nemaline rods on muscle biopsy in the same and/or in separate muscle fibers. 4 genes have been revealed as the genetic cause of core rod myopathy, and both autosomal recessive and dominant cases are known. Cap myopathy is a very rare congenital myopathy, with the occurrence of caps as a typical histopathological feature. Caps are peripheral, well-demarcated areas that stain eosinophilic with hematoxylin and eosin, and dark blue with nicotinamide adenine dinucleotide tetrazolium reductase. They show no adenosine triphosphatase activity and no myosin staining. They react with antibodies against actin and actinin. Using electron microscopy, the caps comprise focal peripheral areas of disorientated myofilaments, usually with thickened Z discs and thin filaments. Between 4% and 100% of the fibers can show caps, and there exists a correlation between the number of affected fibers and clinical severity and the age of the patient. 5 genes are known to cause core rod myopathy. Finally, zebra body myopathy is an extremely rare congenital myopathy in which muscle biopsy shows the presence of zebra bodies as filamentous structures with thin dark lines alternating with thicker dark ones, as well as other myopathic changes. ACTA1 is the only gene identified so far to be the genetic cause of zebra body myopathy. 3. Centronuclear myopathies. Centronuclear myopathies typically show nuclei located in the center of the muscle fibers. The nuclei are usually larger than normal and have a vesicular appearance, particularly in the X-linked form. This congenital myopathy subgroup comprises the X-linked recessive myotubular myopathy caused by mutations in the myotubularin 1 gene, MTM1, and the autosomal dominant or recessive centronuclear myopathies caused by pathogenic variants in 8 different genes. Central nuclei in neonates are on oxidative enzyme stains typically associated with dark stained centers with a pale peripheral halo. The halo contains myofibrils, but only few mitochondria. This pathology is like that seen in congenital myotonic dystrophy type 1, neonatal Steiner disease, which must be excluded by genetic testing in the differential diagnosis with X-linked myotubular myopathy. 4. Congenital fiber type disproportion myopathy. The congenital fiber type disproportion myopathy subgroup of congenital myopathies is defined by selective atrophy of type 1 muscle fibers, with the mean type 1 fiber diameter being at least 35% to 40% smaller than the diameter of type 2 fibers. No other structural abnormalities may be present on the muscle biopsy. To date, 10 genes have been shown to cause congenital fiber type disproportion myopathy, and both autosomal recessive and dominant inheritance patterns are known. 5. Myosin storage myopathy. This congenital myopathy used to be named hyaline body myopathy because of the presence of hyaline bodies in the muscle fibers. However, since heterozygous mutations in MYH7 have been identified as the underlying genetic defect, the term myosin storage myopathy is preferably being used. Hyaline bodies are focal regions visible as granular, slightly basophilic zones with hematoxylin and eosin and not stained with nicotinamide adenine dinucleotide tetrazolium reductase, but positively stained with adenosine triphosphatase and slow myosin, in contrast to the staining pattern of CAPS. On the ultrastructural level, the hyaline bodies are recognized as granular regions. Myopathies excluded from the initial congenital myopathies classification. Historically, 3 muscle diseases have been classified with the congenital myopathies, but are currently no longer considered part of this group. 1. Sporadic late-onset Nemaline myopathy because of a late-onset, rapidly progressive course. Lack of clarity concerning a genetic or, rather, an acquired cause, since some cases are associated with a monoclonal gammopathy or human immunodeficiency virus infection. 2. Spheroid body myopathy and sarcotubular myopathy caused by pathogenic variants in the tripartite motif containing 32, TRIM32, and myotolin, MYOT gene. These entities are now classified with the limb-girdle muscular dystrophies and myofibrillar myopathies respectively. And 3. Reducing body myopathy caused by mutations in the 4.5 limb domains 1, FHL1 gene, because of a rapid progression and severe disease course. Differential diagnoses of congenital myopathies. The most important differential diagnoses of congenital myopathies are congenital muscular dystrophies, congenital myotonic dystrophy type 1, metabolic myopathies including Pompe disease, congenital myasthenic syndromes, and spinal muscular atrophy, which can all occur at neonatal age with severe weakness and/or hypotonia. Elevation of serum creatine kinase more than 5 times the upper normal value should orient towards a congenital muscular dystrophy. Muscle pseudohypertrophy should suggest a muscular dystrophy, for example, Duchenne or limb girdle muscular dystrophy, or Pompe disease. Tongue fasciculations are suggestive of denervation, most commonly caused by spinal muscular atrophy. Extreme joint hyperlaxity can be a severe clinical feature of congenital myopathies due to RYR1. However, it is more often associated with a collagen VX disorder, such as Ullrich congenital muscular dystrophy or a connective tissue disorder. In order to exclude congenital myasthenic syndromes, repetitive nerve stimulation and single-fiber electromyography are important examinations, although neuromuscular junction abnormalities can also be associated with some congenital myopathies, and several congenital myopathies even show amelioration with pyridostigmine, mestinon, which increases the amount of acetylcholine in the neuromuscular junction. Management of patients with congenital myopathies. At present, only supportive treatment, but no curative therapies are available in congenital myopathies. Recently, a consensus statement on standard of care in patients with congenital myopathies was published. The most important issues are summarized here. Importantly, management of patients with congenital myopathies is performed at a specialized neuromuscular clinic by a multidisciplinary team, which includes a pediatric neurologist specialized in neuromuscular diseases, lung specialist, orthopedic surgeon, management of scoliosis and joint contractures, cardiologist, physiotherapist, motor and respiratory physiotherapy, prevention of contractures, occupational therapist, speech and language therapist, dietary specialist, management of gastrointestinal complications and nutrition, neuropsychologist. The neuromuscular specialist has a central role in the diagnosis and management of congenital myopathies and provides the patient family with information on diagnosis, prognosis, genetic recurrence risk if known, treatment plan, and family support and resources. Since gene therapies are on the way, obtaining a genetic diagnosis is necessary to allow possible genetic treatments in the future. The consensus statement recommends that children less than 1 year of age should be followed every 3 to 4 months at the Multidisciplinary Neuromuscular Center and older children every 6 to 12 months. At all follow-up visits, the neuromuscular specialist should monitor for respiratory, swallowing, and speech problems. Regular monitoring of respiratory function, including sleep studies, and promptly initiating non-invasive ventilation and cough assistance are crucial in some patients with congenital myopathies. Cardiac signs are a rare primary presentation of certain congenital myopathies, TTN, MYH7, rarely ACTA1, or more frequently as a complication of respiratory insufficiency, cor pulmonale. In general, it is recommended to screen patients with asymptomatic congenital myopathies by a cardiologist every 2 years, especially in patients without known genetic cause. More frequent cardiac evaluations are indicated in case of overt cardiac symptoms and/or electro/echocardiographic abnormalities. Orthopedic complications such as scoliosis and joint contractures should be checked at each visit. Growth, height and weight should be measured at each visit in order to detect early failure to thrive. Regular aerobic exercise such as swimming, hydrotherapy, and cycling is advantageous, although no scientific evidence is available. In congenital myopathies with prominent respiratory involvement, for example SCPN1, prophylactic pneumococcal and influenza immunizations are indicated. Furthermore, malignant hyperthermia in some patients with ryanodine receptor 1, RYR1 mutations needs to be considered. Congenital myopathies and malignant hyperthermia. Malignant hyperthermia is defined by hyperthermia, muscle rigidity, and hypermetabolism as a result of using triggering anesthetic agents, particularly volatile gases and depolarizing muscle relaxants like succinylcholine. Malignant hyperthermia is a medical emergency that is treated with dantrolene, which antagonizes the intracellular release of calcium by the ryanodine receptor 1, and additional supportive care measures. Malignant hyperthermia susceptibility, MHS, is suspected in an individual with congenital myopathies in cases where 1. There is a positive family history of MHS, 2. There have been previous problems with anesthesia, and 3. The patient has a proven RYR1 mutation. MHS has also been demonstrated in congenital Native American myopathy caused by mutations in the SH3 and cysteine-rich domain-containing protein 3, STAC3 gene. The in vitro contraction test on muscle biopsy tissue, although not routinely performed, is the definitive diagnostic test for MHS, although little evidence supports the presence of MHS in other genetically defined congenital myopathies. The general recommendation is to avoid depolarizing muscle relaxants and volatile anesthetics in congenital myopathies when possible. In congenital myopathy cases without known genetic defect and/or nonspecific histopathological features, MHS needs to be taken into account in anesthetic management. Pathogenesis of congenital myopathies and emerging therapies. Most proteins that are implicated in congenital myopathies are related to primary or secondary defects of muscle excitation contraction coupling, intracellular calcium homeostasis, and abnormal sarcomeric assembly and function, although other mechanisms are also being suggested. The underlying pathomechanisms of congenital myopathies are reviewed elsewhere. Current and future therapeutic approaches to congenital myopathies are elaborated in other reviews. Gene therapy trials are evolving, in particular in X-linked myotubular myopathy. Recently, the effects of MTM1 gene therapy using an AAV8 vector have been demonstrated in MTM1 mutant dogs with obvious long-term advantages on muscle weakness and pathology. Furthermore, a phase 1/2 multinational open-label ascending dose delayed treatment clinical study is ongoing to evaluate safety and preliminary efficacy of a viral vector carrying the MTM1 gene at 132 in individuals with X-linked myotubular myopathy aged less than 5 years old. An interim analysis presented at the 2018 World Muscle Society Congress has reported increased limb and trunk strength, improved velocity and accuracy of movements, advanced ability to communicate, recovery and secretion management, and swallowing capability. Challenges in congenital myopathies. Like many other genetic diseases in recent years, congenital myopathy single-gene testing has been largely replaced by next-generation sequencing technologies based on massive parallel genetic testing. Newer technologies are continuously being further developed. Now, mainly gene-targeted exome sequencing or whole exome sequencing are being applied in diagnostic genetic laboratories. However, RNA sequencing, RNA-seq or transcriptomics, and whole genome sequencing are even newer techniques that will most probably be applied in routine diagnostics in the future. Using gene-targeted exome sequencing, gene panel, a final genetic diagnosis can be made in a maximum of half of the cases. This can be explained by several reasons. Only known genes are included in the predefined gene panels. Mutations in the intronic regions of the genes are not sequenced, only exons. Certain genetic defects such as deletions or duplications or repeats cannot be identified with the current techniques. This also implies that certain differential diagnoses, such as myotonic dystrophy type 1, caused by increased repeat length in the DMPK gene, or Duchenne muscular dystrophy, in case of a deletion or duplication in the DMD gene, cannot be diagnosed differentiated using the currently available next-generation sequencing technologies. By applying whole exome sequencing, or next-generation sequencing technologies in general, a large number of variants is being generated in a genetic analysis, and it is often a challenge to identify the variants that are pathogenic and thus disease-causing, in contrast to sequence changes that are non-pathogenic polymorphisms. Pathogenicity prediction software programs can help to a point in this endeavor, but further necessary support comes from clinical and paraclinical diagnostic workup, including muscle magnetic resonance imaging and muscle biopsy. Thus, the sequence of examinations performed in patients with a muscle disorder is changing and will continue to change in the future. Genetic sequencing will be increasingly performed before a muscle biopsy. In cases where a known pathogenic mutation is identified, further histopathological examination by muscle biopsy may no longer be needed. However, in most congenital myopathies cases, the muscle biopsy will remain an important tool to enable interpretation of the many genetic variants of unknown significance. With an increasing number of congenital myopathies being genetically solved and gene therapies widely developing in muscle disorders, and congenital myopathies in particular, a challenging and exciting future awaits us in the field of neuromuscular diseases.